Welcome to This Explainer. I am so thrilled you're here with us today. Look, if you think you know what an ACL surgery looks like just because you or a buddy had one, say, 10 years ago, well, you might want to think again. The science, the surgical techniques, even the recovery timelines, they've all evolved completely. So today, we're diving straight into the ultimate modern patient journey of ACL reconstruction as it stands in 2026. Okay, let's dive into this. Picture it. You're out on the field, or honestly, maybe you're just coming down off a weird step. You plant your foot, you twist, and pop. Right away comes that immediate swelling, the intense pain, and that absolutely terrifying feeling of your knee just giving way beneath you. It's an incredibly anxious moment, right? But what exactly happens next? How do we get from that terrifying split second on the ground all the way back to peak performance?
Here's our medical roadmap for today. First, diagnosing the torn ACL. Second, protecting the growing knee. Third, choosing the right graft. Fourth, advanced upgrades like the LET and meniscus repair. And finally, rehab and returning to sport.
Starting right off with step 1, diagnosing the torn ACL.
So you're sitting there in the doctor's office, just waiting to find out what's wrong with your knee. And you're probably thinking, an expensive MRI is the absolute gold standard, right? The only way to know for sure if the ACL is torn. Well, here's a surprising truth. Research actually shows that when they're done proficiently, simple clinical diagnostic tests done right there in the office by a doctor can be equally or even more accurate than an MRI. Skipping that long wait for a scan can literally save you critical time and money, getting you into pre-op rehab or surgery way faster.
The secret weapons here are 3 very specific hands-on maneuvers. First up is the Lachman test, where the doctor pulls your shin bone forward with your knee slightly bent. This one actually has the highest sensitivity for catching a fresh tear. Then there's the anterior drawer test, which is pretty similar but done with the knee bent at a 90-degree angle. And finally, the pivot shift test, which checks for rotational instability. A highly proficient physician using these specific manual tests can competently diagnose a compromised ACL right then and there. No waiting required.
Moving on to step 2, protecting the growing knee.
Now, when we look at the fastest growing demographic for this injury, which is youth athletes, the stakes get so much higher. Historically, doctors would tell kids, hey, let's just wait until you stop growing to have surgery. But treating active kids without surgery is incredibly risky. In fact, delaying surgery for more than 12 weeks massively spikes the odds of secondary damage. We're talking about irreversible tearing of the meniscus and cartilage just because the knee keeps buckling. So simply waiting, that's just no longer the default answer.
But here's the catch. You can't just perform a standard adult ACL surgery on a 10-year-old. Why? Because kids have open growth plates, also known as physes. If a surgeon drills traditional tunnels right through those plates, it can actually cause one leg to grow longer than the other, or cause the knee to bow inward or outward. Obviously, we don't want that. So, modern medicine developed physeal sparing surgery. It's this specialized technique that carefully routes the new ligament around or completely away from those vulnerable growth zones. And this brilliantly illustrates exactly what that looks like in the operating room. This is called the all-epiphyseal technique. Look at how the surgeons are using specialized real-time X-rays to perfectly position their drills. They stay entirely within the epiphysis, meaning they completely avoid the growth plate. It's amazing because it provides the child with a perfectly stable knee right away, protecting their cartilage, while totally ensuring their leg can just keep growing normally. Which brings us to part 3, choosing the right graft. Once the diagnosis is locked in and the patient's age is accounted for, we hit the next major decision. What actual tissue are we going to use to rebuild this ligament? You've got options here, and it basically breaks down like this. A bone patellar tendon bone autograft is incredibly strong, sure, but it carries a pretty high risk of long-term kneeling pain. On the other hand, taking your hamstring tendon results in less knee pain, but it predictably weakens your knee flexion and sprinting power. Then you have allografts, which use cadaver tissue. These offer the absolute easiest early recovery, but they come with an unacceptable 8.9% re-tear rate in young active athletes. And finally, there's the quadriceps tendon autograft, which gives you high strength while totally preserving your hamstring and sparing you from that nasty patellar pain. As Dr. Romanelli points out here, the medical community is undergoing a massive paradigm shift. Because it offers incredibly strong, durable tissue comparable to those old patellar standards, but with significantly lower pain at the donor site and fully preserved hamstring function for explosive athletes, the quadriceps tendon has rapidly emerged as the absolute new gold standard for ACL reconstruction in 2026.
Next up is Part 4, advanced upgrades like the LET and meniscus. Now, fixing the ACL itself, that's sometimes only half the battle. To guarantee true long-term joint stability, we need to talk about the LET, or lateral extra-articular tenodesis. You see, if your surgeon just replaces the ACL, your knee might actually still be vulnerable to the extreme rotational twisting that caused the tear in the first place. The LET is an entirely separate, additional stabilizing procedure that reinforces the outside of the knee. Think of it this way. Your new ACL is the seatbelt, and the LET is the airbag. For high-risk athletes, like young soccer or football players who just naturally have looser joints, it provides this absolutely essential second layer of armor.
And the impact this has on the data? It's literally staggering. On its own, a standard ACL reconstruction in high-risk athletes can have a re-tear rate hovering around 12 to 15%. But check this out. When surgeons combine a quadriceps graft with that LET procedure, the re-tear rate plummets to just 3%. No way, right? That is a massive, fourfold reduction in the chance of your newly reconstructed knee giving out again. It's a real game changer.
And alongside the LST, we absolutely cannot ignore the meniscus. The meniscus isn't just a simple shock absorber, it actually acts as a wedge that stops your shin bone from sliding forward. If your surgeon misses a sneaky tear in the back of the knee, like a ramp lesion or a root tear, which actually happen in about 15% of ACL injuries, by the way, your new graft is going to be under massive stress and is pretty much doomed to fail. Modern surgery demands that these hidden tears are actively hunted down and aggressively repaired with vertical sutures.
Finally, we arrive at Part 5, Rehab and Returning to Sport. So, the surgery was a success. Awesome. But now begins the longest, hardest phase of the entire journey. Looking at the Ohio State clinical guidelines, you can quickly see that modern rehab is highly structured and incredibly strict. In those first 4 weeks, the absolute #1 priority is regaining your full knee extension and managing that swelling. As you move into the middle phase, the rules get rigid. For example, if you had a hamstring graft, you are strictly forbidden from doing isolated hamstring resistance exercises for a full 8 weeks. You don't even start high-level plyometrics or agility jumping until 12 weeks or even later. And getting cleared to play your sport again? Well, it's no longer based on just guessing when you feel ready. It requires passing ruthless, objective criteria. You have to have a full, completely pain-free range of motion. Specialized machines literally have to prove your leg strength is at least 90% of your uninjured leg. You can't have any reactive swelling after a practice session. And your single leg hop distance must be perfectly symmetrical. Hitting these strict milestones safely, that means returning to play generally takes an entire year or even more.
Which brings us to our final thought for today. The entire landscape of ACL recovery has completely transformed. Knowing what we know now about the crucial importance of clinical exams, protecting those growth plates, utilizing quadriceps grafts, advanced LET procedures, and undergoing rigorous, structured rehab, are you going to settle for a cookie-cutter approach, or are you going to take this knowledge straight into your doctor's office, ask the hard questions, and demand a recovery plan built for the long game? Thank you so much for joining me for this explainer. Keep learning, and I'll catch you on the next one.